There are a few ideas that I would like to introduce to you, you may not know. At this point of time in the 21st century, we have so many things to do. Now, the old way, the information is broadcasted by somebody, and people collect information, right? And you put it in your box and close it. But you never know what is in this box. Now, of course, in the exam, this box has to be opened. Now, this is the wrong way. Now, in the 21st century, the idea is different. The idea is that you collect data. You collect data. These Lego bricks are single pieces of data. You collect data, and it's called data collection. Now, what we do in a lecture, what we do is data management. We shuffle with data, we put them in the right place, and we organize them, and we complete the story. We never put them in the box. We never close the box. Now, people who leave the lecture, they are even refusing to hear. They are even refusing to hear. And they have no idea what is data management. So you need to go and check on the net what is data management. There's even more. We will be talking about the face. Whenever somebody buys something or goes into something, he has to read instructions, right? He has to read instructions. Now, you need extra instructions to become doctors, to learn your medicine. The knowledge you are learning is yours. And you are being instructed here as a data management platform. When you leave, you are refusing instructions. This is what it means. When you leave, said, sorry, I don't need you, I don't need this lecture, I don't need instructions, I know all the instructions. So you are refusing instructions. Very near in the future, you will face this dilemma. Success or failure, or in between, or begging for marks. And the pyramid of knowledge, of learning, which has been used for so many years, says that whatever you read, whatever you sit at home and read only, you gain 10%. Okay? You need audio-visual. You need to see something. You need to demonstrate. You need to discuss. And this is what we do in a lecture. A bit of this and a bit of that. Therefore, when you leave, you are Miss or Mr. 10%. This is what I call it. When you leave the instructions, you are Mr. 10 or Miss 10%. Right? And this place is for smart parking. وفهمك كفاية. Now, we need to study the face because the face is very important. Or do you think otherwise? Problems of the face. There are so many problems of the face. Simple case of acne. Bad face of acne. Do you know what these are called? Black spots, they are called comedones. شوف بين المستر 10% by Mr. and Mrs. 10%. وين يا 10%؟ Comedones, black spots. Simple boils. They appear in faces of people. More complicated cases of infected cysts. Yeah, face wounds. يعني these are common in car accidents due to flying glasses or knives between quarreling people. When you suture this wound, don't look for deep fascia because the face has no deep fascia. And is that a problem? The answer is yes. We will see in a moment. Wounds of the arm, upper limb, lower limb, abdomen, back. There's skin, superficial fascia, and deep fascia. In the face, there is no deep fascia. That means when the skin is opened, the muscles are under your eyes. Wounds in the face are common. Tumors as well. When we have tumors in the face, we need to know lymph drainage of the face. Elevated lesion with irregular margin plus irregular color. These are signs of malignancy, bad signs. When it becomes even blackish, this is more serious. This is melanoma of the nose. This is a bad tumor of the face. This is also secondaries of cancer. Therefore, we need to know lymph nodes. Submental, submandibular, preauricular or carotid, postauricular or occipital, and superficial cervical, ending up in deep cervical. So whenever we see any of these lesions, we suspect something bad, malignant, we have to go to lymph nodes to see how far the process is. Therefore, we need to revive our knowledge of lymphatic drainage of the head and neck.
دكتور الأوكسيبيتال مش نفس البوست أوريكيولار صح؟ الأوكسيبيتال مش نفس البوست أوريكيولار صح؟
لا، ما هو في occipital، في posterior occipital وفي occipital.
أنت حكيت البوست أوريكيولار إنه نفسه الأوكسيبيتال مش نفسه صح؟
لا، نفسه. نفسه. Here's an example. If you have a large mass in the neck, you palpate it, you suspect it's a lymph node, look for something in the face. Now, face wounds should be treated very well if it is under our care because of the scars. People don't like scars of the face. This is fairly good scar. This one is a bad scar, very bad scar. Therefore, you have to have makeup to cover it. This is the mind map you have on your e-learning. Here is a big problem. The story starts here, a simple boil on the nose. So the story begins here, or here. Some people have tried to pick the vibrissae, the hair of the nose, pick them and create a route of entry of infection. Don't pick these hairs. Cut them, don't pick them. Because there is this area which is called danger triangle of the face. Now, why this is dangerous? It is because of venous drainage of the face. Here is a microbe which can get into this dangerous area. So what? But because the venous drainage of this area is going to go to the inside of the orbit through superior ophthalmic vein into the cavernous sinus. Inferior ophthalmic vein also into the cavernous sinus. And then there is this facial vein running from the angle of the eye down to the mandible. And there is this very important vein which is called deep facial vein. This deep facial vein leads to, this is the pterygoid plexus of veins, and the infratemporal fossa. Plus, this plexus also receives other veins from the posterior part of the face and the head, and it is connected to the cavernous sinus. So these microbes, if they get into the cavernous sinus, and the cavernous sinus is going to be inflamed or thrombosed, there is a big problem. This facial vein, especially the deep one, the superior ophthalmic, the inferior ophthalmic, they expose the cavernous sinus to damage, and it's a big damage. It's a serious condition. It is an intracranial infection. Veins of the face. The question is why it is dangerous. Because all this network is valveless. And if one area is blocked, the blood will recirculate. And this exposes the cavernous sinus for more chances of infection. All these veins we were talking about are valveless. This is a case of cavernous sinus thrombosis. Of course, when the cavernous sinus thromboses, there is a problem of venous drainage of the orbit, therefore orbital edema starts. Can this be due to a cavernous sinus thrombosis? The answer is we have so many cranial nerves passing in the wall of the cavernous sinus. And if there is a pathological process going on in that area, these nerves, they stop conduction, and the result is reflected on the eye. Can it be? The answer is yes, it can be. So our story begins here. Patients generally have mid-face infection. Mid-face means dangerous triangle of the face, or sinusitis. Presenting symptoms, the most common is headache. So what? So many causes of headache. Fevers, yes, also it's common for many diseases. But when periorbital hematoma appears, we mark it. This is an indication. Plus cranial nerve sign. One of the cranial nerves is not working, one or more, then it is also an important sign. And in some cases, only cranial nerve abnormalities. There was a question in the exam a few years ago if a young lady developed fever for a few days and then she recovered, but the mother noticed that the eye had squint. What is the possible cause? It is cavernous sinus thrombosis. So test eye movements. There are CT scans of the skull. This place is something we know. This is the pituitary fossa, and you can see the green arrows pointing at normal cavernous sinus. Now inside the circle, there is this whitish area thick around the cavernous sinus. That means there's a problem in the cavernous sinus. This is a bad cavernous sinus. So we need to activate our prior knowledge of veins of the head and neck, arteries, and muscles, because we are going to use them. We need to reactivate our knowledge of the muscles of facial expression. We are using them and we are applying this knowledge now. If this lady has been injured by a knife across the face, and we need knowledge of muscles of facial expression. There is no deep fascia. First, to protect them. Secondly, to cover them. So when we have a wound, the muscles are there. Okay? So if this is the area of the wound, and somebody who is not oriented in anatomy, he is going to suture blindly. Suturing orbicularis oculi with zygomaticus and levator labii and rhizorius. So we need to test facial muscle movements. Close the eye. If this lady is, if something was stitched in the wrong way, when this lady closes her eye, what happens to her upper lip? It will be elevated. So don't do that. You have to have knowledge of muscles of facial expression. Again, what about this wound? in this wound, it is in this area here, angle of the eye, going laterally. If you suture it, blindly you are suturing orbicularis oculi to the temporalis. So whenever this young person eats, his lateral canthus of the eye will be pulled, which is not right. What about this wound? This wound is in the area of just below the angle of the lateral angle of the eye, and it is likely to involve orbicularis oculi and rhizoris and levator labii. Therefore, when you suture it, take care. Different direction of muscle fibers will tell you which muscle is this. Again, another example. Test. This is going to be only in the orbicularis oculi. Now, lines of Langerhans, lines of creases of the face are very important. You should not suture. If you make an incision, make it with these lines. Don't make it perpendicular. Okay? If the wound is due to trauma, you have no choice. And the scar is going to be a little bit more than the patient favors. But if you make incisions, you have to remember these lines. Nerve supply of the face is trigeminal nerve, 95% ophthalmic. We will be discussing this next week. Maxillary and mandibular. At the angle of the mandible, it is not the trigeminal, it is the greater auricular nerve from cervical plexus. Right? So this is the ophthalmic, this is the maxillary, and this is the mandibular area, and this is the greater auricular nerve. Now, if we go into more details, you know that, and we will emphasize on it later on. This is the infraorbital area. This is the supratrochlear, supraorbital, and this is the mental area. You know herpes zoster is a viral infection which gets into the nerve, spreads through the nerve, and create vesicles of that area supplied by that nerve. So this is herpes zoster of this old lady on getting through the ophthalmic division of trigeminal. It doesn't cross the midline. It involves only the upper eyelid, does not involve the lower, and it's down to the tip of the nose, and of course it does not cross the midline, and still the side of the nose is free. This is also herpes zoster of the ophthalmic division. This is herpes zoster of the mandibular. This area, free area, is that of maxillary. This is a typical, nice example of herpes zoster in the ophthalmic part of the division. These nerves we will be coming across when we talk about the trigeminal nerve next week. Blood supply. Blood supply, we have to talk about blood supply of the face for the following reasons. First of all, we need to reactivate our knowledge because you had it in your cardiovascular system. And we are going to to reuse this knowledge and apply it now. Blood supply to the face starts from the common carotid. External carotid. The external carotid will go up and becomes the superficial temporal artery with an anterior branch and a posterior branch, supplying the side of the face and the scalp. A branch which is called the facial artery, behind the mandible, making a notch on the submandibular gland, and then appears in front of the masseter and runs obliquely across the face to the angle of the eye. On the way, it gives inferior labial, continues as facial, superior labial, external nasal, and then angular artery. Then the external carotid will give the maxillary artery into the infratemporal fossa. Then transverse facial, another transverse facial, and then occipital, and then post-auricular. So it has many branches. The face has a very good blood supply. This means what? Wounds heal faster. An area which is very well supplied with blood, wounds heal faster. Now, how can we use this information? It means that when we have facial wounds, we have to remove the stitches earlier. And instead of 6 or 7 days, we remove them at 4 days, so that we do not have risk of infection. Wounds of the face heal faster. Now the veins. The problem with the veins is that they are valveless. Okay? We reactivate our knowledge because we are going to use it. And let's use it now. Supratrochlear, supraorbital. They join and go into the orbit as superior ophthalmic, and continuation as angular vein. External nasal, they make the facial vein. Superior labial, facial vein. Inferior labial, they, at this point, it is anterior to the masseter, and it is going to go deep, and it is going to meet the following. This is superficial temporal vein, and this is transverse vein, facial vein, again another one, superficial temporal vein. It is joined by this big vein, which is the maxillary vein. And it makes this pink vein, which is called retromandibular, because it is deep to the mandible. The retromandibular is going to divide into 2 divisions. The anterior one joins the facial and end up in the internal jugular vein. The posterior one is going to meet the post-auricular vein and create external jugular vein. Very well, good supply of arteries and veins to the face, and ample nerve supply to the face. This is what? This is an example of one of the nerves. This is the infra-orbital vein coming from the maxillary vein, and it is going to branch into the infra-orbital area. Okay? Trauma to the face. Big problem in car accidents. Even the nasal bone is exposed. This young lady was a worker in a factory. And these ladies, when they have long hair and they work in a factory, they should wear a hat. Because rotating things, if they catch the hair, they will pull the hair very forcefully. Now, she was working in a factory and the machine pulled her face and scalp out of her scalp. Okay? She was took to hospital with this face. Now, people who have the knowledge and the experience and the science, the face was put back. Artery to artery, vein to vein, nerve to nerve. Okay? And a few years later, this is the lady. Acceptable facial features. This is called facial transplant. Now, facial bones. You have to reactivate your knowledge because you had your musculoskeletal system, okay, and reuse it. Scalp. Do you know this is an image of what?
Hair transplant.
Hair transplant. Okay? Which is very common now. It's 10%. تعرفوا البانش هذه بكم؟ ما بين 7 إلى 10 دولار. بيعملوا 1000 2000 4000. So it's good business. This is the mind map you have on your e-learning. This is the normal picture of hair. Now there are scopes where dermatologists, they, just like an endoscope, they put it between the hair and they can see this on screen. Now, why we should have a lecture on the scalp? It's because of scalp wounds. Now, any scalp wound more than 10 centimeters, the patient should be admitted to hospital. Very bad scalp wound. But the person who has the knowledge, he can manage scalp wounds. Now, this is a case of trauma to the scalp, but the hematoma, after a few days, came down to the upper eyelid. Now, the scalp has 5 layers. Some layers are safe, some layers are not safe. This is one problem of the hair where it disintegrates. This is alopecia. This is common. Loss of hair in islands of the scalp. Dandruff. Cysts, because the scalp has lots of sebaceous glands, so you expect sebaceous cysts. Black, irregular area in the scalp is very suspicious. This is not black, it's not irregular, but it has a nipple-like structure. This is a sebaceous cyst. very bad scalp wound. Then hematomas. Hematomas this is probably a boxer with a hematoma. Young kids fall around and they develop hematomas. Then we have common problem, we will come to this later, a lymph node behind the ear, which is a very common story. The lady combs her hair or uses a brush, scratches her scalp, infection gets in, lymph nodes get large. She is not aware of the wound, but the large lymph node will attract her attention. These post-auricular lymph nodes are common to see in people. Here is after a fall, not a very serious fall. You can see that the hematoma is developing in the upper eyelid of this young person, okay, after a few days. From which plane? This is an image of somebody holding the scalp of a person. Now, in the 21st century, there should be no such pictures. But the fiction says that Red Indians, when they kill somebody, to prove that he is dead, they descalp the person. Okay, if you descalp a person, he cannot manage to survive. You cannot live without your scalp. Where is the scalp? There is a little bit of overlap. Some people say it's wherever there is hair on the calvera. You know what the calvera is? It's the bone that covers the brain. But there is an overlapping area of the temporal area. Some people say the scalp is not necessarily the hairy area. It comes down to the eyebrows, the insertion of occipitofrontalis. Now, the scalp extends from external occipital protuberance and superior knuckle lines to supraorbital margins, laterally to the zygomatic arch. Layers of the scalp, the skin connective tissue, then the aponeurosis of occipitofrontalis, then the periosteum or the pericranium, and then bone of the skull. Skin is hairy skin with lots of sebaceous glands. Subcutaneous tissue, here we have veins and arteries and nerves, okay, extending into the skin. Then we have the epicranial aponeurosis of occipitofrontalis. Occipitofrontalis is muscular in front. In the middle, it is aponeurotic, and at the back, it is muscular again. And then there's this loose areolar tissue, and this is the pericranium or the periosteum of skull bones. You see the difference between these two images is that these two layers are put as one unit on top of the muscular layer, and we have the loose areolar tissue. Why should we have loose areolar tissue below the aponeurosis? Because we want to move our eyelids, our eyebrows, and the muscle cannot move if it has dense connective tissue with the bone. So we have loose areolar tissue. The scalp is made of 5 layers: skin, connective tissue, epicranial aponeurosis, loose areolar tissue, and pericranium. Skin, connective tissue, and epicranial process, they act as a single unit. So scalp is the skin, connective tissue, aponeurosis, loose areolar tissue, and pericranium. The skin is thick, hair-bearing, many sebaceous glands. Result is good site for sebaceous cyst. Connective tissue is a fibrofatty layer, connects skin to the aponeurosis of occipital frontalis, provides a passageway for arteries, veins, and nerves. But there is a problem here. The artery, when you cut an artery, the artery will contract 50%, and the thrombus will close the rest of the 50. Arteries of the scalp, they are attached by fibrous tissue. They do not contract. Smooth muscle as a reflex, they do not contract, so they remain open, so they bleed. You receive a patient with all his face is full of blood and his clothes, and you start cleaning, and you end up to see 2 or 3 centimeters wound of the scalp. Wounds of the scalp bleed a lot because blood vessels are prevented from contracting of because of fibrous tissue. Okay. This is occipitofrontalis. This is something you know. Here is the temporalis muscle added on the sides, on the temporal area. This is the occipitofrontalis. Okay. And here's the zygomatic arch, supraorbital margin, and superior knuckle lines. The aponeurosis is a thin tendinous structure. Insertion of occipitofrontalis laterally continues as temporal fascia. Contains temporalis muscle. Subaponeurotic space extends to the upper eyelids. So hematoma will end up as black upper eyelid. Okay? Several arteries supplying the scalp, and we need to reactivate our knowledge of the blood supply and the venous drainage. This is the problem. Why a person cannot live without a scalp? Why should we take care of wounds of the scalp? It is because of the emissary veins. Veins of the subcutaneous area will have little holes, and they are connected to diploic veins. You know what is diploic? It's the layer between outer and inner table of the flat bones of the skull. These diploic veins are connected to deep dural venous sinuses. So an infection can spread very easily. So this is the superficial veins going through emissary veins to the diploic veins and then to the dural venous sinuses. This is a way of route of infection into the intracranium. So this is the problem. Extracranial infection becomes intracranial. Loose connective tissue area, venous connection to the dural venous sinuses, especially the sagittal ones. So this is the summary of the veins connected to diploic veins. Diploic veins with emissary veins going to inside the dural venous sinuses, and they are valveless. So nothing prevents them. Back to the hematomas. If a hematoma crosses a suture, then this is in the subaponeurotic space. After a few days, it becomes sagging down to the upper eyelids. But if the hematoma is stopping at the sutures, right, there's a hematoma here, okay? It does not cross to the other parietal. It does not cross to the frontal. It does not cross to the temporal. That means it is subperiosteal. Okay? So that's the loose areolar tissue. We have gone through this. Here is a suture. Okay? This hematoma is crossing a suture. This is safe. No problem. Okay? And this hematoma is not crossing a suture. This one is even more confined. So look what it happens. This hematoma is going to dissect the periosteum. It separates the periosteum from the bone. And when it does that, crosses the suture and becomes intracranial. It was extracranial and now it is intracranial. Okay? But extradural. And that is going to press on the brain. So hematomas that do not cross a suture are dangerous. بتشوف hematoma, tense bleeders are still collecting blood. Put your hand and go around it. If it crosses a suture, say, okay, this is subaponeurotic. If it stops at the suture, and then you check on the other side, also stops at the suture, this is subperiosteal. It may find its way inside the skull and becomes intracranial. These are the layers. Now you hit a person, trauma to the scalp. If it is subaponeurotic, okay, still it's dangerous, but it's not a big problem. But the pericranium is a big problem. Subperiosteal hematoma forms in the shape of the skull bone, and it does not cross a suture. The morale is then the skull sutures. Okay. Here is a CT scan of computerly colored. Here is a hematoma. Okay. Although it is not elevated a lot. It's not elevated a lot, but the CT scan proves that it passed through the suture and became intracranial. This is X in the scalp and resulting into intracranial. Another bad one. These are the nerves supplying the skull. supratrochlear, supraorbital, zygomatico-temporal, auriculotemporal, lesser occipital, and greater occipital. We will talk about this also in case of trigeminal nerve. Many sources of nerve supply. 6 sensory nerves on each side. So we have 12 nerves supplying the cranial nerve. Hematoma of the eyelid after a few days. This is in the subaponeurotic base. Lymphatic drainage, anterior part to the parotid. It goes to the submandibular, deep cervical lymph nodes. Posterior part, posterior auricular, occipital lymph nodes, and to the deep cervical lymph nodes. This is the story of the lady who combs her hair a little bit. The end. Thank you.